the Sono4U team for inviting me to speak. I always get really enthused by all the energy for the ultrasound that is in the med students. And hopefully today I can sort of put a little bit of context and scope around how you might be using ultrasound and inspire you to get really good at this, because there's good reason to be good at ultrasound. So in my opinion, ultrasound is the hero imaging modality. It's, I might be a bit biased, maybe, just a smidge, but you know, it certainly beats CT and MR. They're expensive. It's really readily accessible. The price of machines has come down quite a lot now, and so it's really accessible for everyone. It's also a modality that you can do great things with and save lives, or just even just reassure a patient. And so we have my title of my talk is Breaking the Barriers Through Ultrasound, and it's kind of this tool that crosses all medical disciplines and allows you to break the barrier with your patient, because you have to get up personal and touch your patient, and allows you to communicate with your patient. But it also, because it's across all the disciplines of medicine, allows you to break down some of those barriers and those silos that exist between the different disciplines of medicine, if we can kind of put the politics aside. So, as Uncle Ben said to Peter Parker, with great power comes great responsibility. And I think that this is true of ultrasound. It can be a fantastic tool, a really fantastic tool. But in the wrong hands, it can be dangerous, and it can lead to a lot of trouble. And part of that is making sure you're skilled, and part of that's making sure you're trained well to make sure that you get the right diagnosis and manage your patient in the right way so that you're not being dangerous. So I wanted to start with a bit of a personal story that sort of has confirmed my belief that every single medical graduate should have some skills in ultrasound. Some time ago now, right back at the beginning of the journey at Ultrasound Training Solutions, before we changed our name to Zedu, I personally had this trip to Sydney planned. So I get on a plane, going to a meeting to meet with our professional society, where we were arguing the case that sonographers could teach doctors how to use ultrasound at the point of care. So in Australia, we have sonographers, and they're like specialist technicians that just do ultrasound. They're not doctors or medically qualified. It's kind of, we come from a nursing background or a radiology assistant background, and then just specialise in diagnostic ultrasound. And so we were having this big meeting to argue the case that you know, we were able to teach doctors how to use ultrasound at the point of care, because we were the experts in how to get good pictures and get a good picture so that the diagnosis was right. It was a big meeting, and we were anticipating a bit of heat and a bit of trouble. And you know, I'll go to any sort of lengths to get out of some meetings, but I wasn't quite planning on this. So we landed, I touched down in Sydney, and caught a train out to where the venue was, and met our colleagues, and walking up the hill, and all of a sudden I felt this really sharp burst of pain in my tummy. And I was like, oh gosh, I don't know if I need to go to the toilet. I don't know if I need to be sick. I don't know if I've got a bug, but oh my gosh. But I pretended like nothing was happening because we've got this meeting. We went on up to lunch, and I had to convince the restaurant staff that no, I hadn't been drinking excessively at lunch, but I had been quite ill, and they're like, yeah, likely story. But, and sometime during the meeting, I kind of just slumped down on the chair and realised that I was lying down when my colleagues kind of said, don't mind Suean, she doesn't usually lie down in meetings. And I thought, am I lying down? I kind of sat up. And then we kind of walked back to, we'd done our prep and had the discussion, we walked back to have the meeting, and as we're walking back, I'm like, this is bad, I'm in a bit of trouble here. And so we get to the offices, and I remember their white couch well, because I was very worried about my dirty shoes on their white couch. And as I arrived there, I was kind of thinking, I think I need to go and see the doctor, because I think this is getting a bit bad. Wasn't a doctor. We ended up calling the ambulance, and as my colleagues kind of left the room, I said to the paramedics, I'm 6 weeks, 6 days pregnant, and I think this is an ectopic. And all of a sudden it became clear that the quick scan I had done on myself the night before, what I'd seen. And at the time, because I was preparing to go to the meeting and I had a 3-year-old running around, and I didn't have a full bladder, and I wasn't doing it on a conventional ultrasound machine like this sort of exam in my clinical practice we would do transvaginally and we'd do on a top-end machine. So I was a bit not so confident on a point-of-care system. And I thought, it's not quite right, but when I come back from that meeting, I'm going to go and get a proper scan done. And anyway, it turned out, no, I didn't get to go to the proper scan. I had an ectopic, and it had ruptured. So as I presented at the emergency department, my blood pressure was doing something like this, and it only got worse from there. I had an ultrasound machine that showed nothing in the uterus. It showed some free fluid in the right upper quadrant. It showed free fluid in my pelvis. There was fluid everywhere. I remember saying to the doctor who did the scan, can I have a look at the picture, please? And she said, oh, you're not going to see your baby, dear. I said, I know. Can I have a look at the picture, please? And she kind of turned it around, and I swore a lot because it was like, oh shit, I'm in trouble. I don't know if I'm allowed to swear, but I just did. And so then I had a very quick journey. I was in the emergency department only 25 minutes. And what was going to be laparoscopic surgery turned into an open laparotomy very quickly because I crashed and I was needing to be operated on really quickly. So I think of that journey, and I think if I had to wait for a formal scan, I wouldn't be here to tell you about my story. And I also think of that journey in the context of I probably would have ended up in the operating room anyway. But this way I went to the operating room and they knew what was going on. They knew what to expect. They're not just kind of going in there blind. And when you're the one they're cutting open, that's quite reassuring. But it's interesting because this story kind of continues the next day when my colleague, who had no idea what was going on, rings me. And I foolishly answered the phone because I just wanted anything to distract me from the fact I'm in a hospital. And she had a doctor who had been to one of our courses the week before and had learnt about FAST and AAA exams and a bit of heart. And this emergency doctor had then gone back to their workplace and thought that it was now appropriate with the skills FAST, AAA and heart to now do an assessment in the first trimester and to tell the patient, I think the baby, that there's a fetal demise. Look, we'll just make sure and have it confirmed by radiology before we send you for a D&C procedure. And so my colleague rang me, and this wasn't the first time we'd had this stern conversation, and she was angry. She said, what are you teaching these doctors? And we were not popular because we were teaching doctors ultrasound because it was a betrayal of our profession and, why are you teaching the doctors this? We should be doing, sonographers only should do this. And so I don't know if it was just the amount of morphine that I had on the pump or what, but I kind of got a bit more adventurous in rebuffing her this time, and I said to her, look, they're doing it anyway. I want to teach them to be safe. I want to teach them about what their limits are and how to be safe using ultrasound. If they're doing it anyway, someone's going to teach them. I'm mindful of your comments as a sonographer, and I understand, and I'm kind of sitting on the fence. I'm kind of earning a living from this now. But all that just melts into nothing because right now I've been the patient and I couldn't care what you say. You're not going to win this argument with me. If we look at this purely from a patient's perspective, the politics kind of dissolves into nothing. So that was very early on in the journey of Ultrasound Training Solutions, or Zedu. And it certainly has inspired me to make sure that we're teaching doctors to be safe using ultrasound and teaching you where your limits are with ultrasound. So what I'm hoping to just get across in the next little while is the utility and scope of ultrasound, look at a couple of cases, ultrasound in action, and then just a couple of words on training to get you thinking about how you're going to get yourself skilled in this modality, because if you're good at it, it can really help. So as these machines have got more and more compact and cheaper and more accessible, and even small enough to put in your lab coat pocket, it means that you can, do an ultrasound on just about anyone. And at some stage during a patient's journey through the hospital, any discipline of medicine might do an ultrasound on that person. And so it's become a really, really handy tool in your toolbox. Used to use the stethoscope, and now you can actually see what you're doing. You don't have to just kind of listen and hope. You can actually look. You used to do a clinical exam, well, now you can use the ultrasound to supplement that. And again, you can look and confirm what you're doing. And so if we look at what the International Federation of Emergency Medicine and how they define a point of care ultrasound exam, it's structured to answer a clinical question or a set of questions. It's a focused exam, usually performed at the bedside. This definition always amuses me because every ultrasound I've ever performed has been beside a bed somewhere. It's complementary to the physical exam. It's generally performed in suboptimal conditions. So when I see a patient as a sonographer, they're usually fasted, they've got the pain meds going, I can usually roll them around. You get to scan them in squishy beds, they can't roll around so much, they're in pain often, so the conditions that you're performing them under are not as ideal. And you've got the lights up blaring, we turn the lights down so we can see everything clearer. So you get to perform these in suboptimal conditions. And the other definition is that it's not a replacement for a consultative radiology exam. And for me, a comprehensive radiology exam is an entirely different examination to the point of care scan. They have completely different aims and objectives. If we look at the scope of practice that the College of Emergency Physicians uses, you can use ultrasound in a resuscitative capacity. So as you're doing resuscitation on a patient, monitor your efforts at resuscitation, make sure they're working, and if they're not, try something different. You can use it to diagnose, much like Dr. Fluriard. I don't know, I can't say German words that very good. But use it, is it the heart or is it gallstones? Monitor symptoms, to do therapeutic monitoring. So if someone comes in short of breath and you're giving them Ventolin, they had wet lungs when they got there, you can actually see whether that medication is working and whether the lungs are getting drier because of the medication, and monitor that in real time. And last but not least, for procedural guidance, there's a whole host of evidence out there that says that the procedures are much safer and more efficient and have better outcomes if they're guided with ultrasound. So the point of care exam is set out to answer a clinical question. You should be approaching the exam with an idea of what you think the answer is. So you're not going in there as this vague fishing trip. I haven't got any idea what's going wrong. Oh, why don't we pull out the ultrasound? That's not how to use it well. You want to have an idea in your mind. Is this gallstones? Yes or no? Is there fluid in the tummy? Yes or no? So if you're asking a question that doesn't have a yes or no answer to it, then it's probably a scan that needs to be done in radiology or a comprehensive exam. So it's a really structured exam with a binary outcome. The other thing that it allows you to do is manage your patients in a time-critical fashion. My journey through the ED was very much quicker because I didn't have to wait for ultrasound, and the formal ultrasound to come from radiology and around. But we can do scans and get answers in real time and change drug management and change the treatment plan on the fly based on the images that we're seeing. So if we look at a couple of cases in the emergency department, imagine that the bat phone rings. I don't know if you call it the bat phone here, but the emergency phone that says a really drastic case is coming in. And they tell you that there's a 20-year-old male who's had a stab wound to the middle of the chest, and he's coming in 20 minutes. So this is great, gives you time to prepare your chest tube trays and get the cardiothoracics team down and get everything prepared. Your patient arrives. He looks like this. And while everyone sits there and goes, you know, swing into action, you realise that on that initial assessment, the air entry is even, that he's got the tubes in place, he's got equal air entry. You know, he's doing reasonably well. They can't find a central pulse. And so now it's like, that looks pretty bad, that knife in the chest. Is this a salvageable situation or not? And so ultrasound in this instance can be used to demonstrate whether this is someone that is resuscitatable. I don't know if that's even necessarily an English word, but that if this is a patient that is savable versus someone that, you know, it's inevitable that this patient's going to die. So if this patient has a tamponade, then we can do something about it. But if this patient has pulseless electrical activity, it stumps. And so in this case, he did have a tamponade. So they could crack open the chest, they put a drain in, drained off the fluid, packed it up a little bit, sent him off to theatre, and he went home. He survived the injury, which is quite impressive. Another case where a 70-year-old gentleman presented to an emergency department sort of in a kind of on the edge of Melbourne. So it's not quite the country, but it certainly doesn't have the facilities of the big city hospitals. So they don't necessarily have a CT scan there, and they don't have surgeons on call there, and so it's kind of the first stopping point for the people further out in the country, and then decide which big hospital that they need to go to. And so he kind of presented and is feeling a bit unwell, a bit hot and cold flushes, had a bit of abdo pain for 24 hours or so. And whilst he was in the emergency department, it starts getting sicker, and they thought the doctor who was looking after him is an ultrasound enthusiast, and he was like, I'm going to use the machine, I've got one. And so what he finds is this 6 centimetre aortic aneurysm that's dissecting. Did a couple more, you can see the dissectional flapping away there, and it gets a bit scary. And probably a bit of fluid that it's leaking as well. Used the colour to demonstrate that that was the aorta and not the vertebral body or something else going on. It definitely was the aorta. And so then he proceeds to go, holy moly, we need to get him to a bigger hospital that can cope with this, and has that political argument trying to convince the hospitals that he needs to fly them to, will you take this patient? And you know, there's a bit of argy-bargy going on. They're like, no, you have to define whether this is a type A or a type B dissecting aneurysm. He's like, can I just get him out of here and somewhere else that you can do something about it, regardless what it is? Anyway, unfortunately for this patient, he died in the emergency room just as the helicopter landed on the helicopter pad. But he went from, you know, just feeling a bit unwell to really, really sick very quickly. Another case in the emergency department, imagine this is your grandma. Imagine she's a bit doddery, she's fallen over, broken her hip. Her x-rays kind of look like this. She's already spent a few hours on the floor before someone found her, so she's in a bit of pain. And so in the emergency department, they can now do an ultrasound-guided femoral nerve block to manage her pain. And so it becomes a completely different hospital experience for grandma because she's not in as much pain anymore. And so in anesthetics, whether it be a simple nerve block in the emergency room as a pain management tool, because she mightn't be able to go to surgery for another 24 hours yet. So if you can keep on top of the pain and keep her in a better position, she's going to have better outcomes after the surgery as well. So, you know, the emergency physicians can do simple nerve blocks, but the anaesthetists, previously the way they used to do it, I remember my husband looking at this and going, what, they just hack and saw until they touch and the leg wriggles? And then that's how you know you're in the nerve? And yeah, pretty much. Really? Why don't they use the ultrasound? Well, now they can, obviously. You know, not so many nerve stimulators. But the other thing using ultrasound in anaesthetics, it means that you can decrease the volume of anaesthetic agent that you're using. You can be more precise with your placement of the agent, and so you can get a better nerve block because of it, and also have less systemic toxicity because of less anaesthetic agent. So here's a case where they didn't really. So 65-year-old guy who went for a routine sort of elective knee replacement surgery. And they didn't have ultrasound in their anaesthetic department. And so on this one, you can see this white blob here next to the round black circle. That's the femoral nerve. Now they're pretty close together. So it's easy to see. I look at this. As a sonographer, I've scanned thousands of DVT studies and had never ever seen the femoral nerve until we had to learn how to teach the emergency physicians how to do a femoral nerve block, and all of a sudden it's like, that's a big nerve. It's always been there. I've never seen it. I was never looking for it. And then I wonder, how the heck do they ever get that in without getting it in the artery all the time? And I know myself, I had a total knee reconstruction, and I had a femoral nerve block for post-op pain management as well. And I remember asking the surgeon, how do I know you're going to put it in the right spot? And he said, oh, well, you think about it. You're medical, think about it. And he left me stewing on it for like 3 hours. And of course, I'm a patient now. I don't think when you're a patient. And then I said, no, you're going to have to tell me. And he's, oh, well, we withdraw back, and if we get blood, it's in the wrong spot. Good. So going back to our 65-year-old guy who's had elective knee surgery, he's had a blind femoral nerve block, except 20 mils of ropivacaine has been injected into his femoral artery, direct route to the heart. So he arrests on the table. So the emergency team gets that was in one of the regional hospitals, so he gets evacuated to the Metropolitan Hospital, spends 3 weeks in intensive care with multi-organ failure, goes home without his knee reconstruction surgery, and has a very different quality of life now because of this multi-organ failure, all for the sake of using ultrasound and being able to see where you're putting the nerve and not make that mistake. In the intensive care, again, someone who's had an elective procedure. So a healthy patient who's electively had their aneurysm repaired. She's 1 day post-op, all's going well. And then all of a sudden she collapses. And so the routine advanced life support procedure is, I understand, I've never had to do it obviously, but I understand your first step is, give them adrenaline, and along the way after you've checked their airways and all that, but then adrenaline first and moving right along. But again, in this case, there's a doc there who is a bit of a dab hand with ultrasound, and he said, oh, she's had an aneurysm, let's just see if it's extended up or see if there's any problems because of the aneurysm. And so what he sees is this. And in this particular instance, we have an empty heart, and because there's not enough volume in the heart, the mitral valve leaflet is obstructing the left outflow tract and is obstructing flow of fluid out of the heart. And so giving adrenaline in this case is making the heart pump harder and is making this situation worse. And so in this life and death situation, this patient's gone flat, giving her and following the standard procedure actually makes her sicker, whereas we can see with ultrasound and just have a quick look and realise, you know what, we just need to put some fluid up. Let's fill her heart a little bit and it'll fix the problem. And that's all it took. But it was very counterintuitive to what the normal process was. But they might have just been resuscitating this patient for ages before they kind of got to, well, we're right down the bottom of our list of options and let's try some fluid now. So you can get to fixing the problem sooner rather than later. In family medicine, ultrasound can play a part. It can be as simple as finding a foreign body. Foot, hand, foreign bodies are notoriously tricky to find and dig out, and you can use ultrasound to guide the removal. You can use ultrasound just to find it and then cut down on it, whatever your preferred method is. They're quite easy to, some foreign bodies are really, really easy to see on ultrasound. Otherwise, it's kind of like hunting for a needle in a haystack. It might be as simple as the pregnant patient who's had a bit of bleeding, who just needs reassurance that, yes, this baby's in the right spot and there is a heartbeat. And, then they can relax and stand down from all this anxiety and kind of go back to enjoying their pregnancy again. And that, no, that's not, if the baby's in the right spot, that's not a life and death situation, but it certainly makes a big impact for that patient from an emotional point of view. And if anyone knows anyone who's pregnant women are particularly vulnerable and particularly prone to being kind of emotional, and especially when you've got babies involved. So being able to say, no, there's a heartbeat and everything looks okay, can really change the pathway of that pregnancy. It might be that your 40-somethings have decided it's time to get fit again, having their midlife crisis, and they start to go running, and they have the classic sort of presentation, oh, it felt like someone kicked me in the calf. And so now we need to figure out, is this a torn medial gastroc or is this a torn Achilles? And so it's a really simple diagnosis. If it's a torn Achilles, they need surgery. And the sooner that they get surgery, the better the outcome for that patient. If it's a torn gastroc, go home, rest, ice, elevation, compression. So in this one, we can see some tendinitis in the top pictures, and in the bottom pictures, you can see the break in the tendon and it's a torn Achilles. And again, a really easy sort of scan to perform where you can see a torn medial gastroc muscle. So all that's great, but you've got to get to the point where you can recognise this stuff and use ultrasound responsibly and use it well and make the right decisions and optimise your image well enough and get good enough pictures so that you get the right diagnosis, because without a good image, you can't get a good diagnosis. So you need to understand how to use the machine well and to get good pictures. And that's half of it. Then you need to know how to manipulate the probe so that you can get the best window. Like I said, without a good image, you can't get a good diagnosis. And if you haven't got a good diagnosis and the right diagnosis, then you can manage the patient in the wrong way. And so that requires training. It reminds me of a case where I was at the Children's Hospital and I was working for one of the equipment manufacturers, sort of locuming for them, doing a day and filling in. And they were trying to sell the machine, so they needed someone to stand there and show people the buttons. And I'd been given very explicit instructions, you're not to do heaps of training. That's not what we're there for, that's not what we're paid for. And this case for me was professionally really, really challenging, because there's this 3-year-old kid who's 3 days post-cardiac transplant. I watched 4 doctors come in and use the ultrasound machine. Well, the ultrasound machine was in the room. And I watched 4 doctors make 13 punctures and progressively crash the vessels on both sides until they called the big boss, who forgot that it just went not using the ultrasound and did it blind and got access on this kid. And they were all really cross at the machine. And it was hard, because I'm like, it's not the machine's fault, it's yours, and I really want to tell you that, and I can't. But it just illustrates that, just because the ultrasound machine's in the room, that doesn't fix the problem. I always love it when a patient says to me, geez, these machines are clever. And I feel like just going, why don't we just let the machine do it? So imagine, if it can be just the machine that does it, then yeah, they are clever. But the machines are nothing without you holding the probe and you getting the pictures. So it's the operator that makes the difference. It's you that makes the machine sing, and it's you that makes the diagnosis. And so it's really important to bear that in mind and think about how you're going to get your training. There's a lot of material on the FOAMED world. On our website at ultrasoundtraining.com, we have a FOAMED tab where there's over 90 different resources of free ebooks, websites with case studies. There's all sorts of stuff. There's a Phantom compendium there that's got just about every single recipe that's ever been printed by anyone who's published an article on how to build a Phantom. Work your way through them, that's quite fun. There's a whole lot of education available for you out there that is free. Some of it's really good, some of it's not so good. There's some paid stuff that's really good and some that's not so good. The problem about learning ultrasound on a video is that it's only half the picture. So I want you to think about this for a minute. Imagine you're going to learn how to do the piano. So you think, you know what? I'm going to watch a YouTube video on how to play the piano. Now, I think we can all agree that we can sit and watch a YouTube video and be able to say, he can play the piano really well and he can make lovely music, and they're really bad at the piano. And we can, if we watch enough videos, we can tell who's a good pianist and who's not, who's practiced a lot and who hasn't. But then you might pull up a lesson on how to play the piano. And if that's all you do, and then you expect that you're going to go and sit down at the piano and all of a sudden be able to play the piano, then you're kidding yourself. And ultrasound is like that. It's easy for us to learn and watch others and recognise others who are good at doing ultrasound. And it's easy for us to recognise patterns when we are watching others who are experts at getting the pictures by watching them. But you can't learn how to do ultrasound entirely by watching a video. There's a whole lot that you can learn, how to use it or when it's appropriate to use. You can practice your pattern recognition, what's normal, what's abnormal. You can refresh yourself on the technique. There's a lot that you can learn, but the crux of it comes down to having that probe in your hand or sitting down at the piano and trying to make something that sounds like music. And so when you're thinking about how to get your ultrasound training, it's important to think about practice and drip feeding. You can't just come to a conference for 4 days now and think that at the end of 4 days you're going to be an expert and you're going to go away and play the piano like a concert pianist. It's a joke. It's taken me, I'm still working on my ultrasound skills and I've been going at it 20 years. And it's always a work in progress. And ultrasound's a real art form. So you need to drip feed, like if you're growing a new crop, drip feeding your new crop or drip feeding your new skill and doing multiple short bursts of practice is going to be far more beneficial in developing your skill than if you just flood the crop once every 6 months or once every 2 years or whatever. Flood it and build up and re-inspire yourself, sure, but think about how you're going to practice this day by day to develop the skills over a long time. Practice puts brains in your muscles. And it is something that you have to practice and you have to work at developing this skill. It doesn't just come easy because you've watched a video. You have to actually hold the probe in your hand and develop the skills. So before I wrap up, I just wanted to throw it out to the floor there for anyone who has any questions.
Yes. Are there any questions in the room? No questions so far. I'm also going to check the live stream if anybody has got some questions there, but as it seems, no questions right now.
I never know if that's a good thing or a bad thing.
But you do have a question. Yes, please. I'm just going to hand you the microphone.
Hi, Suean. Hi, Suean. How are you?
Great.
Question from a fellow Australian. What do you think the most basic or one of the easiest skills to pick up is when someone first starts learning ultrasound? What do you think one of the first examinations they should learn is?
I think one of the most useful and one of the easiest ones that sort of teaches the orientation is probably vascular access. And performing lung is easy, interpreting lung is harder. Interpreting the images and then managing is harder, but the actual getting the pictures is pretty easy. A fast scan is always popular and it sort of forms the staple of many beginner courses because people want to know how to do it when patients are crashing, but it's not necessarily the easiest thing. I start with scanning the bladder because it's a fixed structure and it doesn't move and it's pretty uniform in shape between person to person, it's not as prone to pathologies and stuff as some of the other organs, like an aorta, for example. You've got to contend with bowel gas. If you've got a bigger patient, it can be hard. And then if they've got a curly one or pathology, it can be very confusing, and so it's not necessarily a simple study either. So the vascular access in terms of its utility, being able to get a line in a hurry, but also just the probe moves are quite simple, and it also just teaches you that the fine, the big movements and then the fine detail movements, that you can sort of finesse that stuff on something that's kind of stays in the one spot.
Well, I'm glad we do have a vessels workshop right over there, and all of you will have the opportunity to practice these skills in the upcoming days. Well, thank you so much for your wonderful...
I just was going to quickly sum up and wrap up sorry, Vanessa, now my battery's run out, which is a real nuisance, but anyway. So I started this talk with ultrasounds breaking down barriers. I want to imagine a world where politics and this sort of interdisciplinary fighting, oh no, this one's working, that the politics didn't matter so much, and we just strictly looked at this from a patient's perspective. And certainly my own personal experience has been supportive of the fact that I think every medical graduate should have basic skills. Having said that, you need to be aware of how important it is that you are skilled in it and that you develop the skills really well, because if you just be a bit of a cowboy with this, it can be quite dangerous. And so with great power comes great responsibility. We owe it to our patients to get good at it, and if you're good at it, you can be the difference for your patients. So thank you very much.
Thank you very much.